So I am privileged to introduce our first speaker of the 2022 series, Dr. Paul Christo. And he's going to present his talk on pain in the human economic crisis. And Dr. Paul Christo is an MD and an MBA. He's an associate professor in the Division of Pain Management at the Johns Hopkins University School of Medicine. He was the director of the Multidisciplinary Pain Fellowship Training Program and the Blaustein?
Yes, Blaustein.
Blaustein?
Blaustein.
Blaustein Pain Treatment Center at the Johns Hopkins Hospital. He lectures internationally, serves on journal editorial boards, teaches, co-edited 4 textbooks on pain, and has published over 100 articles and book chapters. Dr. Christo is the author of Aches and Gains, a comprehensive guide to overcoming your pain hosts. Overcoming Your Pain. He hosts Aches and Gains, an award-winning national radio talk show on overcoming pain that airs weekly on Sirius XM Radio, and is a frequent contributor on multiple television networks on pain and addiction. And I think that's it. Okay, so his research interests include thoracic outlet syndrome, pain education, aging, and pain. And I got to have that tripping on my words, which I usually do. I'm going to invite you folks to come forward if you like. And without further ado,
Thank you, Angie, and thanks to the Notre Dame Clinical Alumni Network for hosting this and for inviting me. And thank you for attending on a football weekend. So, by way of introduction, I'm a Notre Dame graduate, 1990, and then currently I am an associate professor in the Division of Pain Medicine, Department of Anesthesiology at Johns Hopkins University School of Medicine. So I'm a pain specialist primarily now, and also an anesthesiologist, but I really don't practice much anesthesia anymore. We have a pain clinic, and I've been working there for many, many years. So let me start. How many in this room have pain or know somebody who suffers from pain? Yeah, so really almost everybody. And you're not alone. The pain may be in the neck, it may be low back, it may be in the thoracic spine, it may be headache. So the top 3 pain conditions are typically some type of headache, osteoarthritis, low back pain, and then neck pain. Or it may be more esoteric. It could be something like complex regional pain syndrome, or it could be, for example, diabetic painful neuropathy. I mean, there are a lot of painful conditions that exist, and fortunately that we have treatments for. Pain really has become an epidemic. You've heard a lot about the opioid crisis and the opioid epidemic. I'll talk about that. But even before that, pain has reached epidemic proportions. In 2011, the Institute of Medicine advanced a report that indicated that over 100 million Americans suffer from chronic pain. 116 million, actually. A lot of pain, sadly, remains untreated, undertreated, and has remained and become a significant public health problem. Pain, based on the data, based on the evidence, but even not only based on the evidence, in the literature, but if you see patients who have pain, you know that chronic pain leads to financial loss. It leads to a loss of who we are. It can lead to a loss of who we are as human beings. It can erode us gradually in time. It can lead, because there's a huge emotional response to pain, it can lead to depression. And because, imagine, for example, that you have chronic pain in your left hand. Well, anytime you move it, it causes pain. So you can naturally understand how you're going to be afraid to move that hand or that arm, the right arm or the left leg. So anxiety can develop as a result of having chronic pain. The economic costs are huge, up to $635 billion annually. And what we've learned from the science, from preclinical studies in animals, is that once pain becomes chronic, it becomes a disease in and of itself. It's not just a consequence of other diseases. There are changes that occur in the central nervous system, in the spinal cord, actually in the periphery too, but in the spinal cord especially, and in the brain, that leads to the disease of chronic pain. So 2 days ago, when I was packing for this trip, I developed a paper cut on my, I think it was the left finger here, the left ring finger. What happened when I did that? Well, there are special receptors in the skin, elsewhere in the body too, but in the skin called nociceptors. And when I developed that paper cut, pain then, that sensation, it's actually called nociception before it's called pain, but that noxious stimuli traveled from my finger down the arm to the spinal cord, and then from there to the brain. But let's look at that more closely, see what really is going on there. This is an example of a pain receptor called a nociceptor. I love this picture actually because it's very colorful. It's from a textbook of some colleagues of mine at Hopkins who have since retired, actually. But I like the color, and I also like how it describes what happens with tissue trauma. I mean, you'd never imagine, right, that all these processes occur with just a paper cut like I developed in my finger. What it shows is this, that with tissue trauma, there are a host of inflammatory mediators that are released from cells, like macrophages, other cells. Let me see what I have here. Yeah, like mast cells, macrophages. So you have histamine release, for example, from mast cells. You have prostaglandins that are released from mast cells. You have inflammatory mediators like cytokines that are released from macrophages. And all of these inflammatory mediators, right, all of these chemicals, if you will, these molecules, have receptors to which they bind on the peripheral nerves, on the nociceptors. Well, what happens is, once that happens, so with normal pain, it binds to the receptors, it's transduced, and then it's transmitted from that nerve cell all the way to the cord, and then from the cord to the brain. Well, look what's happening also, though, on the right-hand side. So we have all these inflammatory mediators that are released, bind to receptors on the nerve cell. Fortunately, we have an inhibitory system that you can see on the right that helps dampen those signals. What dampens it? Endorphins are released, right? Endogenous opioids. They bind to specific receptors on the nerve cell. GABA is also released, which is a dampening, that binds to a specific receptor that dampens the pain signals, fortunately. So there's a host of things that go, and by the way, you can see here on the left-hand side, like this TRPV, you see this TRPV1 receptor here? TRPV1 receptor responds to heat, hydrogen ion. Well, guess what? We have a medication now that targets this particular receptor called capsaicin. Anyone heard about that? Capsaicin? It's derived from hot chili peppers. So it binds to that receptor, it's an agonist. It defunctionalizes it and thereby reduces pain. Pretty fascinating, I think. FDA approved for diabetic peripheral neuropathy in the feet. Also for postherpetic neuralgia, chronic shingles pain. Well, we looked at the periphery, now let's look at what happens in the spinal cord, right? So a lot of research in animal studies has demonstrated what goes on in the spinal cord with pain transmission, normal pain transmission, but also with chronic pain. What you see here is on the left-hand side, you can see that nerve cell, right, that nociceptor that's synapsing with the spinal cord, the dorsal part of the spinal cord. On the right-hand side, see the C afferent terminal? That's the pain neuron that's synapsing with the spinal cord neuron. Well, over time, what happens is, so normal signaling releases neuropeptides, and then that, those signals are transmitted from the spinal cord up to the brain. But what happens is that with chronic pain conditions, the system gets overwhelmed. So you get a lot of release of substances like glutamate, which is a neuropeptide, substance P, CGRP. So you have a huge release of these neuropeptides. They bind to the spinal cord receptors. Now we start getting increases in intracellular calcium. We get protein kinases that are activated. What happens ultimately is that you get the generation of, it influences genes. CFOS is one of those genes. But it influences those genes such that you get gene transcription, which then leads to the perpetuation of chronic pain. Central sensitization is the term that we use that means changes that occur at the level of the spinal cord due to nerve injury, but also due to chronic pain conditions. Talked about the periphery, right? The nerve cell in my finger, talked about the spinal cord. Now, let's talk about the brain. What happens in the brain? Well, there's something called the pain neuromatrix. It consists of several areas in the brain that contextualize pain. They communicate with each other to ultimately produce the experience that we describe as pain. But there are several areas. This was described actually in at the end of the 20th century. We're now understanding a little bit more about these areas and how they come together basically to cause pain, for us to interpret this experience called pain. But there's several areas involved. There's the insular cortex, right? The insula, for example, is important in self-awareness, in motor control. There's the amygdala, which is an emotional center, right? The limbic system. the anterior cingulate cortex, the thalamus, which is involved in sensation, pain modulation, consciousness, and sleep. They all communicate together to create this experience that we call pain. Now, in the past, we thought all of this was static. We thought that the nervous system was very static. It's not. It's a very dynamic system. And that's why we see the development of chronic pain, because the neurons change. Actually, what we've learned from the science is that in patients with chronic low back pain, there's a reduction in gray matter in certain portions of the brain, which is sort of scary. The good news, though, is this, that with pain treatments, via functional MRI imaging, we can see those areas normalized. We don't want chronic pain, we don't want acute pain to become chronic, right? And there's a lot of research that's been going on to try to figure out how to prevent acute pain from becoming chronic. We can treat chronic pain, no question about it. It's better, though, not to develop it. These are some pictures of what chronic pain looks like, and acute pain too. The picture you see on the left here, this gentleman right here, is a patient of mine who has, does anyone know what this is? Herpes zoster, exactly. Acute herpes zoster, shingles. This is a severe case of it. He's an attorney, retired now, but when this occurred, so this is affecting the ophthalmic division of the trigeminal nerve. Look how erythematous it is. Couldn't open his eye. I mean, huge amount of periorbital edema there. When the vesicles burst and they scab, and that's what you're seeing in his forehead. So I don't think he couldn't work for, 4 to 6 weeks. I mean, it took a long time for him to recover from this. Today, what he looks like is more like what this woman has in her forehead. You see those circular, those hypopigmented areas in the forehead? Well, that's what he's left with in the forehead and part of the scalp. It's hard for him to bathe. He can't tolerate water because the touch of the water droplets creates pain. The term for that is allodynia. He can't wear hats, can't wear caps, he can't brush his hair, because that area is so tender to touch. Now, he has achieved good pain control with medications, and actually I've injected Botox, botulinum toxin, along that area of his forehead for pain reduction. He gets about 30% relief from Botox. Does anyone know what this particular chronic pain condition is? It's called complex regional pain syndrome. Pretty devastating, as you can see. This is a woman who had no function at all of her ankle, of her toes, couldn't move her ankle, could barely move her toes. You see how much edema she has there. Erythema. What you can't tell is how much allodynia she had. Can't tolerate the sheets. No way could she bathe that extremity. Can't tolerate touch of anything, even, pillows, socks, water droplets, no way. Now the good news here is that, believe it or not, spinal cord stimulation helped reduce her pain so she could tolerate physical therapy. She underwent physical therapy, and today she's at least able to sort of walk on crutches. Before that, she was just relegated to a wheelchair. Clearly, from the data, from the evidence, chronic pain affects us multidimensionally, socially, leads to social isolation. Physically, right? There's no question that the pain is physical in wherever we have it in the body, and emotionally. And did you know that 1 out of every 3 Americans suffers from chronic pain? It really is that frequent. Worldwide, anyone know how many people worldwide suffer from chronic pain? Any guesses? 1.5 billion people suffer from chronic pain. A lot of patients of mine will say, Dr. Christo, it's so frustrating because no one believes that I have pain. They don't believe that I have low back pain. They don't believe that I have migraine headaches and I have to take 15 days off of work a month, that my job is threatened. They don't believe that I have fibromyalgia. They can't see it. Pain is often felt to be invisible, and often it is. Now, it's not invisible in those pictures that I showed you. There's clearly pathology occurring in those patients. A lot of the time there isn't, and it leads to a lot of frustration, anxiety, angst on the part of those who have chronic pain among between the patient who has pain and family members and friends, because they feel like, well, God, can't you just get over this? You look fine. Why can't you work full time? Why can't you go to the movies with me? It's a source of frustration because it's invisible. And as a result, people search high and low for pain relief. I mean, over-the-counter remedies, certainly NSAIDs, braces, herbal therapies, Chinese therapies, injection therapies, platelet-rich plasma, you name it, and they search for it. I think, unfortunately, part of this is a result of the fact that they don't know where to turn. There aren't a lot of pain specialists in the United States, or in the world for that matter, so it's not that easy to figure out what's available for a given pain condition. Pain touches all of us at some point during our lives, right? Actually, sick babies in pain undergo a huge number of painful procedures, say in the ICU or in the hospital. Nasogastric tubes are placed. They undergo a lot of sticks from needles, IV placements. We don't know yet whether that predisposes infants to the development of chronic pain. It may. 20% of all children suffer from chronic pain. Young adults, so that would be most people who are here at Notre Dame, right? Ages between, say, 13 to 23 or so. Recent data, 11% of young adults suffer from chronic pain across the world. I was surprised to see that, frankly. What is that pain? Musculoskeletal pain, primarily. Musculoskeletal chronic pain. As we age, unfortunately, the risk of developing chronic pain increases. It doesn't mean that we can't have healthy aging. No question about it. We can. The risk, however, increases because, we're more susceptible to, say, neurologic diseases, sometimes neurodegenerative diseases like Parkinson's disease that can lead to chronic pain. Multiple sclerosis, not necessarily in older age, but that certainly leads to chronic pain. But stroke can lead to post-stroke pain. Not easy to treat that either. Acute herpes zoster, right? Shingles can lead to chronic pain in the form of post-herpetic neuralgia. And cancer. So cancer can erode the nerves, can erode the organs, and lead to chronic pain conditions. Well, fortunately, if we're spared chronic pain during all these phases of life, it may attack us at the end of life in palliative care settings. No question about it then. Pain really has become and is a human and economic crisis. Problems to access exist. 25%. This data actually is not horribly current. I couldn't find even more current data than this, but I wanted to give you a glimpse as to what the struggles are. 25% of patients wait 6 months or more to get treated for pain. 40% never get help at all, and only 5% are treated by pain specialists because there aren't enough of us available across the country and certainly across the world. And get this, the World Health Organization estimates that 1 out of every 10 people alive today risks dying a painful death. I don't know if you knew that. Most people don't. And that's sad, right? And that exists not only in underdeveloped countries, but developed countries like the United States, Canada, Europe, for example. As I said before, I think that chronic pain has become a humanitarian cause, a pressing humanitarian cause, and it's become a cause of universal dimensions. Here are the figures on how many suffer from chronic pain in the United States and worldwide. It's a large number of people. You've heard a lot, I suspect, right? So how many have heard about the opioid crisis and the epidemic? I'm sure most people, right? Exactly. So it's prominent in the media, television, all forms, print media, TV, radio. And I understand why, and it makes sense. We've had a huge number of deaths related to opioid overdoses. And that's a public health concern, no question about it. Over 100,000 overdose deaths in 2021. 60% of those have been related to synthetic fentanyl. What we've seen, well, initially, when this was reported, probably in 2016, with the CDC guideline that was published, they reported a quadrupling of deaths related to opioids from 2001 to 2016. And that's a major problem, a major public health problem, no question about it. And there was an argument that, pain specialists, physicians, other healthcare practitioners were responsible because they failed to consider the addictive potential of opioids. They failed to consider their low therapeutic ratio and a lack of effectiveness based on the data, especially for chronic non-cancer pain. Long-term data is sort of lacking there. Well, what's happened is that there's been a shift from And actually, I maybe should rephrase this, because I just don't believe that even before this opioid crisis, that there was a focus on the undertreatment of chronic pain. There really hasn't been yet, but we've had even more of a shift from those that are suffering from chronic pain and the need to treat them to overdose deaths related to opioids. And this has led to unintended consequences. We've seen physicians, other healthcare practitioners, as a result of the 2016 CDC guideline, quickly taper patients from opioids, right? Or stop opioids altogether because they felt like it was dangerous. And they didn't, and this was for patients who were legitimately using opioids for legitimate chronic pain conditions. And that led patients to the street to purchase, say, oxycodone or Percocet illegally to help control their pain. Based on a survey that was done a certain number of years ago, 40% of 3,100 patients surveyed online contemplated suicide as a result of that, which I think is tragic. We had pharmacies limiting opioid prescriptions to 1 week at a time. I don't know if that's occurring now, but it did a certain number of years ago. And those that were turning to the street to get opioids were at further risk because we were seeing, and we still see today, tablets that are purchased, say from the street, oxycodone, hydrocodone, laced with illegal substances like heroin, or laced with fentanyl, which ever increases the risk of death. Let's look, though, more in depth about what was going on with respect to opioid overdose deaths. So in general, these deaths, what happened is that in the 1990s, say late 1990s, is that there was I'm sure there was an overuse of prescription opioids for those who had pain, chronic pain specifically. And I think it stemmed from a belief that, from the literature really, that now we had data that suggested that patients who had chronic non-cancer pain, low back pain for example, could benefit from opioid therapy. And it was, I think, done out of good faith on the part of physicians, other healthcare practitioners, because as I said, we have this huge problem of chronic pain. Well, I think that patients probably received these opioids who didn't need them, and who were at high risk of opioid overdose and death. And that's what we were seeing. But that transition from prescription opioid overdoses to overdoses from heroin, and then from heroin to overdoses from synthetic fentanyl. That's what we're seeing today, right? It's really not, and I'll show you the slide in a second, but a lot of the deaths that we're seeing are from synthetic opioids, not pharmaceutically manufactured opioids that we use for patients. A lot of people have gone to the streets to use these mind and mood altering substances to cope. And it's led to publications. This is a good one by certain colleagues of mine who have said, look, we need to make sure that we educate the public that what's going on now in the last several years is really a misrepresentation of the opioid crisis. This is not a prescription opioid crisis anymore. Really, it's the opioid overdose deaths are related to illegal fentanyl and heroin, and I will add another group of substances, psychostimulants, methamphetamine, for example. So, unfortunately, because of the CDC guideline, the treatment paradigm shifted to opioids are bad, we shouldn't prescribe them, they're not really a choice anymore, and that's led to, they say, here, in this particular article, a new public health crisis. I would say an exacerbation of the public health crisis of the undertreatment of chronic pain. $635 billion annually is the cost estimated for chronic pain. It leads to lost productivity, and it also derives from treatment costs. Low back pain, one of the top 3 pain conditions. Almost $200 billion annually for low back pain. Medical costs, emergency room visits, imaging studies, physician visits, clearly, medications, physical therapy, massage therapy, you name it. So there are a lot of treatment costs associated with low back pain. And it also leads to a lot of a reduction in workplace productivity. It's not just low back pain. Certainly migraine headache is another chronic pain condition that can lead to the same type of thing, and lost work days. So, really, pain has become a significant public health problem. It's undiagnosed, it's untreated, and it's undertreated. It affects us multidimensionally. It affects our motivation, our mood, interactions with family and friends, and certainly quality of life. I've had a lot of patients say I will say this, I've had a lot of patients have misconceptions, and family members, with respect to pain. Some have said, look, pain makes me stronger. I don't want any medications. I don't want any treatments. Others have said, no way am I going to use an opioid. Tramadol, no. Any opioid, morphine, no way. I'm going to become an addict. Pain can't be controlled. I'm doomed. It's a curse from God. I did a radio show several years ago, and I named it "Pain is a Curse from God" because I've had patients say to me, Dr. Bristow, I feel like this is a curse, and the pain will never go away, and I'm doomed. The show was interesting. I had two guests on the show. One was a longtime friend of mine, rabbi, that I grew up with in California, and the other was a good friend of mine, longtime friend, Jesuit priest. And they had various different ideas about the aspects of religion and faith that can be pain relieving, and they converged on one point, that is that faith and a faith community can help patients develop the courage they need to continue on, maybe to continue treatments that they're afraid of. And sadly, we certainly have heard a lot about the opioid crisis and how many deaths that are related to overdoses, not only with opioids, but non-opioids. What we don't hear about in the media, though, is that patients in chronic pain have twice the rate of suicide, nearly twice the rate of suicide than others who don't have chronic pain. That's pretty high. The prevalence of suicidal, let me say this, the prevalence of suicidal ideation, that is thinking about suicide, is as high as 14%. And the prevalence of suicide attempts is around 20%. It's pretty high. And you can see why when you talk to patients who have chronic pain. It can be very demoralizing. They can't do those things in life that make it worth living, they feel. Can't play golf, tennis, can't shop, maybe can't work full-time anymore. And, a lot of patients will say, gosh, life as I knew it is over. Now, this pain will never get better. But there is hope. And one of my personal responses to this human crisis of chronic pain was in 2011 to develop a radio show on the topic of chronic pain called Aches and Gains. And it airs on SiriusXM today. It's grown in popularity, actually, since that time, such that I have, I think almost 300,000 listeners per week now on the show. And it has a threefold mission: to provide compelling stories of those who found relief, to provide cutting-edge treatments for those in pain, and to provide ways that patients can cope. I've really tried to do that and to provide an awareness for whoever listens to the show throughout the country, or if they're converted to podcasts or anyone in the world, has an awareness of what can be done, what can they use to make their lives better. And I've had many guests that are everyday people like you and me, but I've also had celebrity guests like Jennifer Grey, talked about neck pain. And she talked about, for many years, she had whiplash injury and she thought that's all it was, but she had subtle weakness in her legs. She went to a spine surgeon did an MRI, he found a huge disc herniation butting against the spinal cord. Did surgery. After that, she then has controlled her pain with medications and with certain interventions, certain injection therapies. Her message was this. She was very focused on integrative therapies. Example, chiropractic care. To the exclusion of everything else. She said, and she wanted to make people realize that they should be aware of the possibilities. Don't pigeonhole yourself into thinking that just chiropractic might work or just injections might work. Be aware of the possibilities. I've had other celebrity guests on the show, though, which I think have been very compelling. The late Prodigy, who's a rapper, talks about his experience with sickle cell disease, sickle cell pain, and how when he was 7 years old, 10 years old, he was at the emergency room multiple times with pain, and how many didn't believe him because pain is invisible. And also they felt like he was drug seeking, just wanted opioids. He described that process, and for him, he used a dietary change to help control his pain from sickle cell disease. A couple domers here, Joe Montana was on the show. He talked about chronic left knee pain. Why did he develop that? Well, from football injuries. He's had, I think, 7 arthroscopies of that left knee. What helps him is glucosamine and chondroitin. He feels like it helps relieve his knee pain and helps allow better mobility. Lou Holtz, right here, Coach Lou Holtz. Spine surgery in the neck and in the low back. Also, we had lumbosacral radicular pain, so shooting leg pain. He had laser disc therapy. Very tough guy. I mean, he refused to use any opioids at all, even post-surgically, just uses Excedrin. But he has benefited from pain-relieving techniques to help improve his quality of life. And allows him to golf. I guess he loves to golf. He's golfs a lot in Florida. He also talked about his wife. His wife, I think, just passed away not too long ago. But at the time, he said, she had squamous cell cancer of the esophagus and had to undergo radiation therapy, surgery. And her faith helped get her through it all and helped her establish the belief things would get better, that God would intervene. And I think he said that he felt a lot of inspiration from her and what she went through. Clay Walker is a country music singer with multiple sclerosis and talked about how exercise is really helpful for him, helps restore his muscle function. And the late Maya Angelou, poet, humanitarian, talked about arthritis and how she takes small steps and how those small steps over time led to one big step that was pain relieving. And for those who are listening, to not give up. Even if it takes small steps, realize in time it can lead to one big step that can be pain relieving. Well, as I mentioned, there are many treatments. I'm going to go through some of these that can ease pain and suffering. There are pharmaceutical treatments that we use, right? Medication therapies, anti-epileptics that reduce pain, antidepressants that reduce pain, NSAIDs, topical therapies, topical lidocaine, topical capsaicin from Hot Chili Peppers, for example. And we have a lot of non-drug therapies that I think are very exciting. I've listed some of them, illustrated some of them here. Physical therapy, first of all, I mean, a lot of patients, I think, with pain end up going to physical therapy. I think it's beneficial for strengthening, say for lumbar stabilization in the low back, core strengthening. It helps patients strengthen and stabilize areas of their body that are in pain and gives them the confidence to improve their function. Cognitive behavioral therapy is underutilized, I think, unfortunately, but can help restore, well, let me say this. I think CBT helps in time transmute the negative thoughts that go through patients' minds all the time who have pain. I'm never going to get better. I'm always going to be in pain, to positive thoughts. And via functional MRI imaging, we've learned, which I think is really amazing, that we have the ability over time to transform those thoughts into positive ones, and those positive thoughts can change that brain neuromatrix that I mentioned earlier. Vagus nerve stimulation, anyone heard about that or no? So this is really new, this is fairly new. This is FDA approved for migraine prevention, and well, actually it's approved for episodic migraine, chronic migraine, episodic cluster headache, and chronic cluster headache. The vagus nerve is the 10th cranial nerve. It travels from the brain down through the neck and then innervates many organs. 80% of the vagus nerve is sensory, and this stimulates the sensory portion of the vagus nerve in the neck for pain relief. Pretty fascinating. I think you use it for like 90 seconds, and you can use it prophylactically during the day to prevent migraine attacks. Really helpful. It was initially developed for epilepsy, chronic epilepsy, and then for intractable depression, but not, it's a surgery that the neurosurgeons place a little lead and so on around the vagus nerve for those other conditions. But now we have a transcutaneous device. There's one that's used in Europe that actually stimulates the inner portion of the ear, which I think is really fascinating, and stimulates the auricular branch of the vagus nerve for pain relief. Then we have epidurals. Epidural steroid injections are widely used. If you look at the data on epidural steroid injections, there's strong evidence that they're useful in the short term, moderate evidence that they're useful for the long term. A recent meta-analysis maybe 3 or 4 years ago indicated that there was an 80% decrease in surgical rate, 80% decrease in surgical rate for those who had epidural steroid injections who had lumbosacral pain from disc herniation. That's pretty interesting. That's pretty notable in my mind as well. Spinal cord stimulation, like sorts of pain pacemaker for the spinal cord, used and approved for multiple neuropathic pain conditions. What we used to call, still many call, failed back surgery syndrome, now called, what is it called? Persistent spinal pain syndrome. So back pain shooting leg pain, for example, neck pain shooting arm pain. Also approved for complex regional pain syndrome. And now recently approved for painful diabetic neuropathy in the feet. Pain pumps. right here. What do we do? High concentration local anesthetic, high concentration opioids, for example. Others, medications can be placed inside that pump chamber, and we can deliver small doses of it to the intrathecal space, the cerebrospinal fluid, for pain relief. Really valuable for cancer pain that's intractable spasticity from, say, multiple sclerosis or spinal cord injury. And the data is such that the efficacy of pain pumps can be, essentially what it says is better pain control with fewer side effects. And it's cost savings. There's cost savings. It's somewhere between maybe 6 months for cancer pain and beyond that, maybe 16 months for those who have non-cancer pain. Peripheral nerve stimulation is new. Look at this right up here, right? Peripheral nerve stimulation. Well, you know, this is pretty amazing too. These leads are about 15 centimeters long. They're thin, they're very flexible, and via a needle, we can place them along damaged nerves for pain control. This is a patient of mine you can see right here. This is her arm, this is her forearm. She's got it outstretched. And there are two stimulator leads there. One along the median nerve to reduce median nerve pain, chronic carpal tunnel pain. And the other is along the radial nerve because she had pain that was at the distal aspect of her forearm and the top 3 or so fingers of her hand. What's interesting here is that she's using a device, so one end of this is along the nerve, the other end of the lead is actually on top of her skin. And it stays there for 2 months. We take it out, and the data, the evidence is such that the pain relief can last for a year or more. How, we don't really understand. Most of the data on this is actually on post-amputation pain, as well as post-stroke pain, post-stroke shoulder pain. But we're using it for other conditions. So damaged peripheral nerves now can be treated with one of these two devices. I showed you the other one here is StimRouter, and there are others, but I just gave you some examples of what they look like. Let me talk about the integrative therapies. More and more patients want to try integrative therapies, which makes sense. This is an example, not exactly an example of acupuncture. This is more an example of acupuncture on the left. Acupuncture is, so the evidence for acupuncture is that it's valuable. Efficacious for neck pain, for low back pain, for knee osteoarthritis, for sciatica, for headache. Not just one treatment though, as many patients want, but multiple treatments, maybe 9 treatments or so over time. I love massage therapy personally. Some patients, like, you know those pictures I showed you earlier of complex regional pain syndrome? Well, you know, obviously they're not going to tolerate massage therapy. However, other patients who have musculoskeletal pain will. And if you look at some of the data, meta-analyses on massage therapy, it indicates that it is effective for pain control, but requires many sessions. Has anyone in the room ever had hypnosis? I haven't, but I'm sort of intrigued. Have you? Yeah. For pain or for something else?
It was just a...
Did you find it useful? For your
not
condition?
in the context in which I received it.
Okay. Well, this is something that's it's not really that known on the part of those who have pain, or I think, you know, pain specialists for that matter. But this is intriguing, and there's data that has shown that it's beneficial for patients who have acute pain, like childbirth pain or burn pain, the burn patients have to undergo a lot of different treatments after that, debridements, for example. But for chronic pain, it can be useful for low back pain, osteoarthritis, fibromyalgia, irritable bowel syndrome. Really intriguing. I did a show on this too. But really intriguing method, and actually the hypnotherapists can train us, patients who have pain, to do self-hypnosis at home for pain control. It works at the level of the spinal cord, so it changes pain transmission at the level of the spinal cord. It also works emotionally on the limbic system to help reduce anxiety. You've heard of lifestyle coaching, right? Well, there are pain coaches as well. They can help support those who have chronic pain. Introduce them to others who have chronic pain, which could be a very supportive environment. Also give them confidence to try new therapies. And give examples of those who had achieved victories over their pain. Patients have asked me, well, should I try some foods? You know, are there foods that I should try to eat that help reduce pain? There may be, right? There's some data on this. For example, try to incorporate anti-inflammatory foods into your diet. Try to avoid some of the pro-inflammatory foods. What are those? Animal proteins. fried foods, fast foods, especially if you have osteoarthritis. Instead, try some tofu, try fish, salmon, for example. Try berries, dark cherries, blackberries, blueberries. I mean, I can't tell you how much to consume, right? Like, how many blackberries should you consume in a day? How many blueberries that could be pain relieving? I haven't seen the data on that. I don't know that it exists yet. But I do know that there is data on the use of anti-inflammatory foods for arthritic control. And some patients, I did a show on this too many years ago, I had one of the guests on the show very, over several months shifted her diet to an anti-inflammatory diet, and it made a world of difference in her arthritic pain. I was impressed myself. I talked about religion before. I think this is probably not as shared by patients. We don't discuss it as much. But faith in a faith community can be pain relieving. It can allow patients to have a supportive environment. It can give you the confidence to overcome the fear to try new therapies. I think that, when patients have chronic pain, several of them have said, look, I've tried multiple medications. I've tried physical therapy. Nothing helps. I don't want to try anything else. I've lost hope. I think with faith, it may be Catholicism, right? It could be Islam. It might be Judaism. It provides a community of people who can give you that courage to move forward. I think that's important. I like scents. I do like aromatherapy. My wife doesn't care for it as much, so I sort of restrict the candle burning to my office in my basement. Essential oils, though, can be pain relieving. I have a patient who wears she wears an aromatherapy bracelet, and she sniffs it several times a day for pain relief. We know that, and these are essential oils, so not just something that you would buy at the store, a random candle, really essential oils. Trigger the limbic system. The limbic system is connected to the autonomic nervous system, which is the fight or flight system, releases norepinephrine, for example, epinephrine. It's also linked to the endocrine system, which releases cortisol, stress hormone. So interestingly, there may be an interaction between all of these molecules that are pain reducing through aromatherapy. Let me talk about some emerging treatments, for example. Emerging treatments, I've listed here, medical marijuana. So cannabis is a hot topic. And I won't ask people in this room if they tried cannabis or if they smoked it. But guess what? What's the #1 medical reason that patients use medical cannabis? Anyone know? Pain, exactly, chronic pain. It may be chronic back pain, I don't know, but chronic pain in general. This is, I think, an intriguing subject, and I've lectured on this. There's a whole lecture on, medicinal cannabis. But suffice it to say that, cannabis, so the products of cannabis, right, there are many, but there's THC and there's CBD. They bind to cannabinoid receptors that exist in the brain, spinal cord, peripheral nerves, CB1 receptors. CB2 receptors are on immune cells. I mean, they're on more and more cells than that, but essentially those are the distinguishing features. CB1 is nerve, CB2 would be immune cells. And we know that we produce endocannabinoids ourselves, right? We produce endogenous cannabinoids that are pain relieving. They do a host of other things as well. So I think there's a lot of potential here. I think, half of the states have legalized cannabis for medical use or recreational use, and some have argued there's no difference between the two. I think where we are with this is that if you look at, there are so many reviews of this, I can't even tell you. Systematic reviews, meta-analyses, reviews of systematic reviews. What do they reveal? Some suggestion of benefit of cannabis-based medicines for neuropathic pain conditions. And yet, if you look at individual studies, we certainly have individual studies that show that inhaled THC can reduce painful diabetic neuropathy or HIV neuropathy. But if you look at the reviews of all the studies, they're not that supportive yet for the use of medical cannabis for chronic pain. And there's inconsistent data for the use of cannabis for conditions like low back pain, fibromyalgia, irritable bowel syndrome, even multiple sclerosis, even though it's approved in other countries in the form of an oral mucosal spray for the spasticity associated with multiple sclerosis. I think for spasticity, it is quite beneficial. For pain, when I've asked patients will ask me all the time, what do you think about medical cannabis? Hopkins does not feel like there's enough data for any of us to share any suggestions for medical cannabis, but patients ask me all the time. And I've asked them, I've said, well, because they're using it, they're inhaling it, they're smoking it, and I have not been that impressed yet, I'll have to say. When I ask them, well, how much relief are you getting from the cannabis, the THC or the CBD? Well, not that much. Helps with sleep, helps with anxiety, is what they'll say. But I think in time when there are pharmaceutical products that are either CBD or related or THC related, I think then when we have the data and the analysis to support it, that it's likely that this will be more helpful. I'm excited about it. Botox I use a lot. Botulinum toxin works in two ways. It reduces muscle overactivity, and it also, based on animal studies, reduces nociception, interestingly, right? So think about some of like the spinal cord and the release of these neuropeptides, substance P, CGRP. Well, Botox helps reduce that release of those chemicals, interestingly. So certainly Botox is used on label, migraine prophylaxis, for example, hyperhidrosis on label, but it's used off label for a lot of other conditions as well. Anyone like music in the room? Does anyone listen to music? Yeah, a lot of people. So do I. It's very relaxing. There was some data that music therapy can be helpful for chronic pain, actually for acute pain. So patients use this in certain hospital settings, audio pillows or earphones during surgery. And there is some data that suggests that it's useful as a pain reliever during surgery and for pain reduction. Also in chronic pain conditions, cancer patients, in palliative care settings. The music can be whatever you choose. There was some data that you should choose slow tempos, for example, that's very flowing. But I think other data suggests it doesn't matter what type of music it is, it's whatever you like that can be beneficial. Well, what about therapy dogs? I did a radio show basically on this, on therapy dogs. I didn't know that this existed, and I looked at some of the data, and there is some data, from some studies that suggest that therapy dogs are pain reducing. I never even knew that. I mean, we have a dog ourselves. My son is right there. And, we have I think isn't this a Springer Spaniel? Does it look like a Springer Spaniel? It does. Anyway, we have a dog that looks like this. St. Bernard? You think it's St. Bernard? No. Well, anyway, yeah, it looks sort of big for a Springer Spaniel. Anyway, the data on this is that therapy dogs have been studied in chronic pain conditions and can be beneficial in reducing chronic pain in patients with osteoarthritis, low back pain, for example, headache. And it only requires like 10 to 15 minutes of the interaction with the animal. The duration of relief exceeds that of the time spent with the animal. When they analyze the serum, the blood of patients who've encountered these therapy dogs, it shows a reduction in cortisol, which is a stress hormone, and an elevation in endorphins, right, which are pain relieving, which I think is really intriguing. What about these regenerative biomedical therapies? Platelet-rich plasma, stem cell therapy, prolotherapy. Prolotherapy is interesting. Has anyone heard about prolotherapy? I mean, it's the use of dextrose, sugar, and it's injected around damaged muscle, tendons, or ligaments. When it's injected, it creates an immune response, and those growth factors are stimulated that heal injured tissue. There is some data on prolotherapy for knee osteoarthritis in 2013, injected into the knee joint, or peppered, if you will, around the knee joint, led to about a year's worth of pain relief. Stem cell therapy, you spin it down, 20 cc's of blood taken to, concentrated to 3 cc's. The platelets contain growth factors. This also can be injected along damaged muscle, ligaments, and tendons. There are studies on the value of this. If you look at the overview of studies related to platelet-rich plasma for pain, they're not that encouraging yet. There's inconsistent data. The data overall doesn't support the use of platelet-rich plasma for these conditions. Musculoskeletal conditions, for example, specifically, muscle tears, muscle injury, or tendon injuries. How about stem cell? I have a friend who is like this huge bodybuilder. He emailed me a couple days ago, and he said, oh gosh, I'm gonna get stem cell therapy injected into my disc. And he sent me an image, which is like a CT scan, I think, of his low back. And, it's not an MRI, which the MRI really reveals much more about the discs than the CT scan. And I said, well, wait a minute now, we should probably talk about this before you spend $2,000 to have stem cells injected into your disc. What does the data show? You know, there's animal data on this, which I think is revealing, and I think it's very exciting about how it can regenerate damaged tissue. If you look at the human studies, there aren't as many human studies, and if you look at the, again, overview of the human studies, it's really felt that a stem cell therapy really felt to be investigational. I think you have to be careful about it. It's not obviously covered by insurance. Platelet-rich plasma not covered by insurance either. I think there is a lot of excitement about that in the future, but I don't think we're quite there yet. I think in the future, we may be able to train our brain to reduce pain. Preliminary work has suggested and shown actually that patients who are in functional MRI imaging, so real functional MRI imaging, and who are exposed to a painful stimulus, acute, can reduce pain by receiving visual feedback from the researcher. It targets one of the areas of the pain neuromatrix at the anterior cingulate cortex. Fascinating. I think in time we may have the ability to do this ourselves. Well, let me say this. I hope I've given you an overview of chronic pain, the processes related to chronic pain, and most importantly, that there are treatments for those who have pain and who suffer. The benefits can be really significant. Mood elevation, improved sleep, wellness, mastery over pain, more self-control over pain. And overall, my message is this: no one is immune to pain, but together we can overcome it. Happy to answer any questions. Thank you. Yes, that's fast.
So you mentioned hypnosis. How about meditation, and also about consciously trying to augment the perception of pain? So pain is discomfort, causes discomfort, correct? So the idea would be something like you still are receiving the information that pain gives to you, but you do something to try to perceive it as less, like you ignore the unpleasant part of it and just take in the information.
Yes, no question. So that is helpful, sort of distraction therapy. I think is maybe what you're describing, is that right? Your thoughts are shifting away from the pain. And certainly there is data to the mindfulness. I didn't talk about that exactly here, but you're right. There is evidence that mindfulness meditation is pain relieving. You need to practice it. You know, the thing is, well, I've noticed that, and I would be the same way if I had pain. You know, I want something that's going to help me within a couple of days. I don't want to wait 3 months. That's the difficulty with cognitive behavioral therapy. And similarly with mindfulness, I think it takes time to develop that technique, but absolutely, I think it can be very helpful. Yes?
My wife had a knee replacement about 3 years ago. No, 3 years ago. And I had to basically do a tap dance on the doctor's head to get, he gave me 2 weeks of pain medicines and then like take Tylenol and Advil. And you know, I finally got 10 more oxycodone or whatever it was at the time. And then we had another issue. She switched doctors and she was on an anti-anxiety pill. Our practice and the orthopedic guys, the practice has decided we're not going to do this. Now this was, the practice has decided we're not going to do this. And in South Bend, there's like 3 practices. There's 3 like mega practices. Has the pendulum really shifted the other way? Because, you know, in England, I don't know, you can get Tylenol with codeine OTC. You know, here you have to sell your firstborn child into slavery, and you still probably wouldn't get it. I mean, you know, like, where is there a happy medium? All us old people are not going to be terminal drug addicts. We just, you know, would even like something, even if, and my wife, you know, if she had a few Tylenol codeines, it's almost a placebo. She knows it's there and says, oh, okay, you know, I really need okay, but, you know, what's the solution here?
I don't think, so the pendulum has not reached a balance yet. It's over to where that pendulum was when I showed you that slide, you know, based on a recent publication. It's, oh, let's avoid opioids. Let's do everything possible to avoid opioids. And again, you know, a lot of this has been through the media, right? I mean, that opioids are, it's based on that 2016 CDC guideline, and it's had unfortunate consequences, and what you described is one of them. that, there are plenty of patients that will come to me who say, oh, my primary care doctor was prescribing, but now they're not going to prescribe anymore. They say they can't prescribe. That's what I often hear. Really, they can't prescribe? We know that they can, but they choose not to. I don't think we're there. It's not back to, center. It's not. I think in time, I don't know how much time, but I think in time we will get there. Not to maybe where we were before, but you're right. If you look at the data on, well, how likely is it for a pain patient, a chronic pain patient? Well, chronic pain, you're talking about acute pain. It's even less for acute pain.
Now she's got chronic pain.
Yeah, how likely is it that someone who has chronic pain is going to develop the disease of addiction with an opioid? Well, we have data from, I think this was maybe 10 years ago at least, large study, thousands of patients were studied, and the risk in those, you have to do risk assessments and so on, but those who didn't have a history of abuse or addiction really had a very low percentage risk of it. It was like less than 1%, right? Now there's other data that indicate that there's a 30% risk of addiction to opioids. But in my experience, and I've been doing this for about 20 years, I've had very few patients develop the disease of addiction to opioids. Now granted, you have to do certain things though. We have risk mitigation strategies, right? You need to do your assessment. There are surveys that we use to assess the risk of abuse, do pill counts, urine drug testing, all these things we did before the 2016 opioid guideline, those of us who are pain specialists anyway. So I think that, and I still do that now with patients who have chronic pain and who require opioids. This is even a problem for cancer patients, right? Cancer patients who had pain, patients who have neurodegenerative diseases and who are on opioids also had struggles getting opioids, right? Getting opioids prescribed. And I'm talking about patients who have Parkinson's disease, who have debilitating pain, multiple sclerosis, sickle cell disease. So this guideline had a very, I think, negative impact. I think this is a long answer to your question, sorry about that. I think
It's a long question.
it's a long question, deserves a long answer. But I don't think we're there, to be honest with you. I don't think we're at the happy medium. Hopefully we'll get there in time, but I don't think we're there yet.
Yeah, so you had mentioned that therapy involving injecting sugar.
Yes, therapy.
Yeah, so I was curious as to how that affects patients with diabetes.
Oh, that's an interesting question. A lot of that is not systemic. It doesn't become systemic. I think there's a small little portion that can become systemic, but very, very little of it, I think, gets into the bloodstream. So it's not, I haven't really seen recent data on that, but it may be similar to injecting steroids, epidural steroids, for example, in those who are diabetic. It does transiently increase their blood sugars, and it may have a side effect on that, but nothing that I've seen that's going to be have a tremendously negative impact anyway.
You presented a lot of different options and even future options. Where does one start? I live in a major city, and so I have access to lots of different things, and I just don't know where to start.
Well, I would start, if you have access to pain specialists, I would start there first. Is that what you mean?
Yeah, are there various, there are pain specialists, but they all seem to be spine surgery people.
That are spine surgeons or that work in a spine surgery practice?
Spine surgeons. Maybe I just haven't found the right. What am I looking at? Spine pain specialist. How do you find that?
You would say probably, I would say pain specialist or interventional pain specialist. It's sort of subdivided. So this is another answer to your question. What's happened in time is that those who don't want to prescribe medications or opioids then refer to themselves as interventionalists and therefore don't want to prescribe anything that's going to do procedures. It's more revenue generating. But you could go to certain websites. American Academy of Pain Medicine, for example, I think has a website locator, and you can type in where you live and they'll show you who's around. Or you can shoot me an email, and if you can, I have my email address up there, and if I have colleagues in your city or whatever, I can happy to share that information.
Thank you. And then you said that chronic pain actually changes the genes. It starts to actually permanently change the nerves.
Yeah.
Could you comment on that for just a second?
Oh, sure. Right. So chronic, what happens is that, and that's that process of sort of central sensitization. So specifically, it's felt that this, it's called C-FOS gene is involved in the genesis of chronic pain. So when you have this bombardment of the release of these neuropeptides and so on, it changes the processing of those signals at the level of the spinal cord, such that the nerve cells become hyperexcitable. And there's a lower response to a stimulus that triggers the painful response, and in time, you don't need any response anymore to trigger the pain. It's just there all the time. So the gene products, FOS is one of those gene products, then combines with another gene product, another protein that then influences the gene in the nerve cells to continue the cycle, right? But that's sort of what we believe happens. In the brain, we're not exactly sure a lot about, but it relates to this pain, the pain neuromatrix that I described there, in those areas of the brain that change. But you know, the good news is that the data also suggests that we can reverse some of that with pain treatments, which I think is very helpful, because I hate to have continued nerve cell damage, that is reduction in gray matter in my brain forever. So, yes?
Going off that idea, do you believe that new technologies like CRISPR with gene editing can be used in pain treatment?
Yeah, so that's intriguing. I think that what we're going to see in time, well, is that we're going to have, and there's been research on gene therapies for pain control in animals. Like you use a vector, right? And the vector is injected intrathecally into the cerebrospinal fluid and directly goes to the dorsal root ganglion, for example, or the spinal cord, and leads to gene transcription that then can lead to the production of endorphins, for example, more endorphins for pain control. I think we'll see that in the future. I'm really amazed by the number of therapies that are available for patients who have rheumatologic conditions or even cancer. All these monoclonal antibodies are amazing. I think we're going to see that hopefully for pain control too. We don't really have them available that much for chronic pain. For migraine, we do. We have monoclonal antibody therapies. So I think we're going to see more of that.
I think this has been fabulous. So thank you very much, Dr. Krista, for your time, and thank you
My
everyone.
pleasure.
Yeah. And if you have any questions, I think we can hang out for a couple minutes, but I know some people have
Gotta
to go to other talk stuff. Thank you very much.